Gastrointestinal conditions, which depends on lifestyle changes, include gastroesophageal reflux disease, GERD, dyspepsia, and diabetic gastroparesis. Gastroesophageal reflux disease is defined as presence of heartburn, regurgitation, or both at least once weekly. Recent studies indicate that the prevalence of GERD in India ranges between 8 to 20%, which is comparable to that in the West. Dyspepsia is defined as having one or more symptoms of epigastric pain, burning, postprandial fullness, or early satiety. Diabetic gastroparesis is one of the gastrointestinal complications of diabetes, in which patient may present symptoms such as early satiety, nausea, vomiting, bloating, postprandial fullness, or upper abdominal pain. Proton pump inhibitors, PPIs, are generally accepted as the standard treatment paradigm for GERD. However, 30% of GERD patients do not experience symptom alleviation with conventional PPI therapy. PPIs are unstable at a low pH. Further dysmotility in GERD cases slows down gastric emptying, resulting in retention of PPIs. Retention of PPIs inside the stomach for a long time result in an impaired acid suppressive effect, so rapid transit of the PPIs to the upper intestine will be beneficial. Prokinetics increases lower esophageal sphincter pressure, enhances esophageal peristalsis, and augment gastric emptying. Hence, there is need of combining PPIs with prokinetics to improve the effects of PPIs, thereby improving GERD symptoms. PPIs are the most effective drugs to control GERD symptoms. However, they differ in their ability to control symptoms rapidly and consistently. Rabeprazole results in a faster onset of action and faster symptom control as compared to other PPIs due to its rapid activation rate. At a pH of 5, activation half-lives for the PPIs vary. Approximately 7 minutes for rabeprazole, about 90 minutes for omeprazole and lansoprazole, and approximately 5 hours for pantoprazole. The rate of heartburn disappearance with rabeprazole treatment is 100%, which is only 86.9% with omeprazole and 82.4% with lansoprazole. The rate of epigastric pain disappearance with rabeprazole treatment is 100%, which is 95% with omeprazole, 95.2% with pantoprazole, and only 82.6% with lansoprazole. Rabeprazole shows superiority over omeprazole in rapidly relieving symptom during the first 3 days of therapy. Comparison of rabeprazole with other PPIs in elderly patients with esophagitis found that rabeprazole is superior to these drugs in decreasing symptoms of heartburn and epigastric pain. Percentage change in emotional distress, sleep disturbance, food or drink problems, and vitality questionnaire is significantly more with rabeprazole as compared to esomeprazole in mild to moderate erosive GERD. Also, rabeprazole is superior to esomeprazole in decreasing heartburn and acid regurgitation. Comparison of rabeprazole with omeprazole for long-term safety in the maintenance treatment of erosive gastroesophageal reflux disease over 5 years showed that rabeprazole is well tolerated. Rabeprazole has almost negligible drug-to-drug interactions in comparison to other PPIs due to prevalent non-enzymatic metabolic pathway. Co-administration of rabeprazole did not affect the pharmacokinetics of theophylline, diazepam, warfarin, and phenytoin, which is affected with other PPIs like omeprazole and lansoprazole. Levosulpiride is the levorotatory enantiomer of sulpiride, a substituted benzamide. It is a prokinetic agent which amplifies the lower esophageal sphincter pressure more speedily and efficiently than other therapeutic agents. The prokinetic effect of levosulpiride is mediated through the blockade of NTRK, inhibitory dopamine D2 receptors. Consequences also show that levosulpiride acts as a reasonable agonist at the 5-HT4 receptor. Levosulpiride improves the dyspeptic symptoms like pain, discomfort, fullness, bloating of abdomen, early satiety, nausea, vomiting, associated anxiety symptoms, and health-related quality of life impaired by dyspeptic symptoms. Levosulpiride quicken gastric emptying. Levosulpiride is more efficacious in comparison to other prokinetic agents, metoclopramide, domperidone, in management of dyspeptic symptoms. Overall, dyspeptic symptom relief rates is significantly high with levosulpiride as compared to domperidone and metoclopramide in patients with non-ulcer functional dyspepsia. Levosulpiride amplifies the lower esophageal sphincter pressure more speedily and efficiently than other therapeutic agents. Rabiprazole with levosulpiride is ideal combination. Rabitero L provides multiple pellet technology. When taken orally, multiple unit dosage forms disperse freely in the gastrointestinal tract. Maximize drug absorption and reduced peak plasma fluctuations. Minimize local irritation of the mucosa by certain irritant drugs and minimize potential side effects without appreciably lowering drug bioavailability. Offer reduced variation in gastric emptying rate and transit time. Hence, intra and intersubjective variability of plasma profiles, which are common with single unit regimens, are minimized. Reduces localized concentration and provides less risk of dose dumping. Improves safety and efficacy of a drug. For assured relief in GERD, diabetic gastroparesis, Rabitero L, the best PPI with superior prokinetic best technology at best price.